I'm Dr. Vivek Gupta. I'm talking about ECMO and overview. I'm thankful to the organizer for giving this opportunity to speak on this topic. Next. The foundation of extracorporeal life support was laid down actually by Gibbon when he developed a cardiopulmonary bypass machine in 1950. For next 10-12 years, this was used for the purpose of cardiopulmonary bypass for cardiac surgical procedures. And in 1971, the first ECMO was started in a trauma patient successfully. After that, next few years, it was used for various indications, such as for a trauma patient or in the meconium aspiration syndrome in the neonates. It was used in the adults as well as in the neonatal and pediatric population. But in 1979, it was a big setback when a National Institute of Health conducted a trial and found the 90% mortality in ARDS patient when they used VA ECMO. And for next 20 years, it was restricted only to the few centers in the world, and mostly it was used for the pediatric and neonatal patients. The reinterest developed after the H1N1 pandemic in 2009 when multiple groups showed beneficial results using ECMO for these ARDS patients. Next. Look at this picture. In 1972, it was such a big machine and big oxygenator, it was very difficult to reach to the patient. But thanks to the technology and miniaturization of the circuit and equipments, now we have such a small oxygenator and a small machine and such a good accessibility to the patient in this figure. Next. This is the report of Extracorporeal Life Support Organization, which is an independent international organization which collects the data for ECMO, and so far they have shown that there are 1,29,037 run with the survival of nearly 50%. But if you look at this data, there is a more survival in the neonatal and pediatric population as compared to the adult population. Next. This is the increasing number of centers every year across the world. Next. So before starting my talk, I would like to discuss few cases which we routinely see in our day-to-day clinical practice. The first case is of aluminum phosphide poisoning. Next, here a 25-year-old young guy who took 3 tablets of aluminum phosphide 1 hour prior to presenting to the emergency department, and when we checked the blood pressure, it was unrecordable. He was restless, tachypneic with a cold clammy periphery. This is a very common presentation of these patients. On examination, we found that he is tachycardic, his blood pressure was just 70/40, and he was rapidly breathing with a rate of 42. We immediately rushed with the 1 liter of fluid, and we continued with the fluid resuscitation, started with the inotropic support and vasopressor. We calibrated the radial artery to do invasive arterial monitoring, and blood gas was sent to this patient. While we were continuing with the fluid resuscitation and inotropic support, the blood gases shows a severe metabolic acidosis and lactic acidosis. A 2D echo showed 18% of ejection fraction with the global hypokinesia. We started with the vasopressin infusion as well because patient was not maintaining his blood pressure. After an hour, the BP did not improve. A repeat blood gas show a further worsening of the acidosis and lactic acidosis. Inotropes were further went up, and echo showed a further worsening of ejection fraction of 15%. Do we expect any improvement in this survival in this patient? Let's take another patient who was a patient of acute coronary syndrome and had a cardiac arrest. This was a 53-year-old patient who presented with a chest pain with the ECG changes. After stabilization, we did an angiogram and we showed an ostial left main disease with a triple result disease. While we were talking to the relative for urgent CBG, patient had a suddenly cardiac arrest. Code blue was activated, high quality CPR was initiated, and even after multiple shock, patient did not improve, and we had to intubate this patient and we continue with the CPR. Next. Though the cause of VF was obvious, we ruled out other causes. Lactates were rising and blood gas was, though unremarkable, a high quality CPR was continued. Even after 30 minutes, with the 15 shocks and continuous CPR, VF was persisting, and family was discussed for the further possibility and the prognosis. Next. A third case, ARDS in a patient with the LSCS. Next, a 26-year-old young lady who underwent LSCS under GA just 2 days back. It was unremarkable, absolutely uneventful. After 2 days, she was tachycardic, tachypneic, and her saturation dropped down to 86%. Other investigations were within normal limits. When we did blood gases, it shows a PaO2 of 56. Because she was hypoxemic, so we managed to get the high flow oxygen mask. She further worsened, and she required a non-invasive ventilation for maintenance of her work of breathing. A 2D echo showed a normal study with no evidence of pulmonary embolism. Her chest further worsened and she required intubation and mechanical ventilation. We had to increase the PEEP and high ventilatory setting. In spite of that, she was not maintaining the oxygen saturation. Next, the X-ray showed a bilateral diffused opacity, a PaO2 of just 48 and PaCO2 was 62 with oxygen saturation of 82%. And in spite of further increasing the PEEP to 20 and proning the patient, she was still with the oxygen saturation of 75 to 80% for next 3 hours. And now she started requiring inotropic support to maintain her hemodynamics, and her urine output started dropping. So do we think that any of these patients would have survived with the conventional management? So let's see what happened to this. The case 1, we started with a VA ECMO. Inotropic supports were reduced gradually. Metabolic and lactic acidosis started improving. Even urine output and acute kidney injury started recovering. And on day 5, we were able to make the VA ECMO off with ejection fraction of 35%. He was weaned off from mechanical ventilation on day 7th and discharged from the hospital on day 12th with a normal LV function. The second case, where it was an emergency and we did a percutaneous VA ECMO establishment quickly while continuing with the CPR. And after doing an ECMO, VF persisted. We shifted this patient quickly to the cath lab, and a PTCA with the left main stenting was done immediately. After that, when we gave shock, it reverted to the normal sinus rhythm. ECMO and mechanical ventilation was continued. We discontinued ECMO on next morning. After 2 days, he was extubated and was made off ventilator, and he was discharged from the hospital on day 9. The third patient, where we did a VV ECMO, arterial blood gases started showing improvement, and we maintained an oxygen saturation of 80 to 90% in this, and we started reducing the ventilatory support. ECMO was weaned off on day 7 and patient was decannulated. On day 10, she was extubated and ventilator was off, and ultimately she was discharged from the hospital on day 40. Next. So we all know that the ICU is a dynamic area, and we come across with a variety of the life-threatening situations such as a cardiac arrest, cardiovascular collapse, acute coronary event with the cardiogenic shock, or intoxication, massive pulmonary embolism where there is a cardiovascular collapse. So we come across with these patients routinely. So what to do when the conventional therapy fails or conventional therapy is not helping us? Next. So we can always debate that for respiratory support we have conventional mechanical ventilation. If it is not working, we can have advanced mode like APRV, ANAVA, HFNV, etc. And for the other cardiac support, we have the inotropic support, other circulatory support like IABP, and we have other devices to remove the cytokine or a CRRT. But the question comes, do we really need such a costly therapy for our patient, which has so many complications which we have read and we learned those complications? To answer this question, we must understand that for what these patients actually dies. Next. So what do these patients die from? Next, the multi-organ failure. The most important thing, ultimately these patients die because of multi-organ failure. You take any of these patients what we have discussed. Next, what happened exactly? There is a ventilator-induced lung injury. Next, we have a cardiovascular effect of the high ventilatory support, means there is a decreased venous return, decreased cardiac output, hemodynamic instability, and we keep increasing the inotropic support, and we keep doing a fluid resuscitation for management of hypotension. Next, so there becomes the fluid edema and fluid overload and organ edema. Next, and ultimately these patients land up with the secondary sepsis in the intensive care unit. Next, and this leads to a worsening of global and regional perfusion of these patients. Next, And every time we all know that when the next organ is involved, the mortality goes high by 10%. So this is what mechanism happens in every ICU patient whom we see dying. So extracorporeal support helps in a different manner in these patients. It is basically a form of extracorporeal therapy where we use the external artificial circuit which carries a venous blood from the patient. So anything which is taking blood from the patient is the venous end. Then there is a device that is called as oxygenator which exchanges the blood, and there is a pump which pushes the blood back after removal of carbon dioxide and adding of oxygen in this oxygenator. It is returned either to a central vein of a patient when we call it as VV ECMO, and returns to an artery when we call it as VA ECMO. So it is, if we say analogously, it is a modified form of cardiopulmonary bypass. The other term we commonly use it as emergency cardiopulmonary bypass or extracardiac life support, but we should always remember that it's a temporary but can be a prolonged support for a circulatory system, for the respiratory system, and secondarily it helps other organ perfusion as well. So what exactly it does? It basically sustains the life. When there is a cardiorespiratory arrest, it supports both heart and lung to sustain the life as we try to do in the cardiopulmonary resuscitation. In the patients where there is a hypoxemia or a hypercapnia, it provides oxygen and try to remove the carbon dioxide, and VA ECMO try to maintain the mean arterial pressure and thus helps in the maintaining the tissue perfusion and tissue oxygenation. So we can say it is actually working like a bridge. So what bridge? When there is a bridge, then what is the destination? So it can be a bridge to recovery in those conditions which are reversible, as in my first case there was a toxic myocarditis where it is a bridge to recovery. In some cases where the lung or heart has failed completely, where it can be a bridge to a mechanical assist device like a LVADs, RVAD, or the lung assist devices, and it can be a bridge to transplant. So any patient who is a candidate for lung or cardiac transplant can be temporarily supported with a ECMO. So it is helpful as a bridge. So the question comes, when to do ECMO? This is very important to make a decision about ECMO. The condition should be reversible. This is the first rule for doing ECMO. And the patient who is not responding to the conventional therapy and the mortality is high in these category of patient. This is the time when you should start thinking of doing ECMO. It is a dictum to say, think about ECMO when the mortality is 50% and do ECMO when you feel that the mortality is as high as 80%. Though with the advancement of technology and our learning, this bar has been reduced, but it's still, the dictum goes this way. And the most important thing, when we want to give rest to the organ, because suppose we can discuss that a patient who is having a respiratory ARDS and a respiratory failure, which is not responding to the conventional ventilation, we keep increasing the ventilation. And secondarily, what happens? We keep running behind the numbers and we keep increasing the stress on lung by increasing the PEEP, increasing the ventilatory setting. Similarly, if there's a failing heart and we keep increasing the inotrope just to going behind the numbers of maintaining blood pressure, probably it is not the helpful modality. It is more important to understand the organ perfusion concept, that we need to sustain the not only the blood pressure but to the organ perfusion as well. Next. So what are the different types of ECMO? It can be a veno-arterial ECMO where both heart and lungs are supported. It can be a veno-venous ECMO where only lungs are being supported. The blood is taken from one vein, major vein, and being returned to the other major vein after oxygenation and removal of the carbon dioxide. There may be some variant of VA and VV ECMO, which can be a VAV ECMO or AV ECMO. So this is the diagram. Next, this is the diagram. You can see this is VA ECMO. Next, this is the diagram where you can see the respiratory support. You can see this, the blood is taken from the femoral vein and the oxygenated blood is going back to the internal jugular vein. So this is the VV ECMO. So this is the patient. Next, we can see this. Where you can see this, there is a femoral left femoral artery. The venous access is taken for the ECMO, and the blood is being returned into the right internal jugular vein. So this is the most common method of doing a VV ECMO in a patient with ARDS. But there are certain double lumen cannula which is not still available in India. So with the single cannula only, we can, through the internal jugular vein, we can do a VV ECMO. But both have its own complication as well as its own advantage. Next, this is the patient of VV ECMO. You can see the percutaneous cannulation, the femoral artery and femoral vein, and you can see in the sheath on the reverse direction, this is actually a distal perfusion in this patient, which is very important to maintain the distal limb perfusion, otherwise there will be a hypoperfusion and gangrene. Next, so if we say the difference between VA and VV ECMO, in the gross sense, any patient who needs a cardiac or cardiorespiratory support, the choice is VA ECMO. Any patient who needs only a respiratory support, the choice is VV ECMO. In cases of RV failure, VA ECMO is beneficial, or in those patients where we want to support the heart or temporarily with the post-cardiac surgical patient, it's a VA ECMO which is the method of choice. Next, so if we look at the indication, the potential indication for VA ECMO is any patient who is having acute myocardial infarction, is having a cardiogenic shock which is not responding to the conventional therapy, fulminant myocarditis, whether it's a viral or toxic or any other myocarditis, acute exacerbation of chronic heart failure. Here it can be used as a bridge because there is no reversibility in these conditions. The cardiac failure due to the intractable arrhythmia, in those cases also temporarily we can put these patients on VA ECMO, or even a post-cardiac surgical patients who are having a cardiac failure, they can be supported temporarily with the VA ECMO. In cases of cardiac transplant, if there is a primary graft failure, or any patient who is having a cardiac arrest. So ECMO CPR, which can immediately, when the conventional CPR is ineffective, the ECMO CPR can sustain the patient till the time definitive therapy can be achieved. Next, the potential indication for VV ECMO, any acute respiratory distress syndrome where the patient is either not maintaining oxygen saturation or patient is having is hypercapnic. Any syndrome which is associated with either viral or bacterial pneumonia. Any graft dysfunction in the patients who are having a candidate of a lung transplant. Any trauma where there is an extensive pulmonary contusion, or any patient who is having a pulmonary embolism. In these, there can be both VV ECMO and VA ECMO, both can be done. If a patient is not having a cardiovascular collapse, only oxygenation an issue, in those pulmonary embolism cases, we can do a VV ECMO to improve the oxygenation. But if the patient is having a cardiovascular collapse in cases of massive pulmonary embolism or cardiac arrest, where the patient should be supported with the VA ECMO. Or in any condition when there is a risk of injury, ventilatory injury, and we are unable to maintain the oxygenation, VV ECMO is the treatment of choice. But before thinking of indication or initiating of ECMO, we must think of contraindication of ECMO, because this is very, very important, that we should not select those patients where there can be a futile exercise, because it's a extensive therapy with a costly thing. So the absolute contraindication, when there is an unrecoverable heart, or there is not a candidate for transplant, or there is a disseminated malignancy with a severe brain injury, or there is an unwitnessed cardiac arrest, or CPR time is more than an hour, or there is a unrepaired aortic dissection, or patient is having a severe aortic regurgitation. There is a patient who is having a severe irreversible neurological condition. So all these are absolute contraindication. The relative contraindication includes the advanced age. There is some contraindication for the anticoagulation, where especially for VV ECMO we can continue for some time without anticoagulation, or there are some compliance issue associated with the cognitive, financial, psychiatric or social limitation. So how to do? I'll just give you a brief overview about how the ECMO hardware works. So next, hardware, disposables, and the ECMO card which contains all articles including the checklist. Next, So in this slide you can see there is a ECMO machine which actually works as a monitor as well as for a generator. So it has a control knob and certain display panel along with the alarm to tell us quickly about any untoward event. Next, this is the oxygen blender. You can see this, there is a knob for adjusting the oxygen and there is a knob for adjusting the flow of gases. So it helps in the oxygenation as well as for the carbon dioxide removal. Next, this is the called as centrifugal pump or pump head. This is basically the heart of the ECMO machine. It works as a heart. Next, and this is the pump head which actually rotates at a very quick speed and it pushes the blood further by creating a vacuum. Next, and this is the lung actually of the machine, that's called as oxygenator. It takes part in the gas exchange. Besides this, this is the material. Next, this is the ECMO circuit for having the PVC of the material, which helps in the connecting from the patient to the machine. So these are the polyvinyl PVC tubings. Next, and these are the cannula actually, because with this we make the connection between the patient and between the circuit. So these are the cannula which are placed. You see on the left side, this is the red color cannula. These are arterial cannula put basically for the return cannula. These are put in the artery or any return vein where we are pushing the oxygenated blood inside the patient. On left side, right side, if you look at, these are the longer cannula. These are the venous cannula which are placed in the vein for drainage of the blood. They are the multi-port cannula. So this is probably the cannulating these patients is the most important step, because if you don't get a right access, your ECMO can never run. So cannulation is the most important technique before initiation of ECMO in any patient. Next, so this is how it looks like. If you look at this, there is a venous line, so blood is coming from the patient, going to through the pump head to the machine. Now it is going to the oxygenator, and then after oxygenator, where you can see this with the green tubing, you can see it is gas exchange is taking place, and then through this arterial line the blood is returned back to the patient. So this is how the whole set of ECMO runs. Next, the most important thing during the ECMO is the monitoring. So monitoring of the clinical parameter, which we do for all patients, but here it is a more extensive monitoring, including the ECG rhythm, heart rate, blood pressure, temperature, respiratory rate, and certain specific for VA ECMO that the right hand saturation is important. We keep checking frequently the arterial blood gases. We monitor the output, and especially in VA ECMO, we look at the echocardiography daily to see the cannula position and cardiac function. And in some cases, if possible, we always look for cerebral oxygenation and nurse. The hematological parameters, we look at the blood sugar levels, blood gases, we look at the hematocrit, urine output, urine color to assess that there is no hemolysis, and to check these, if we are in doubt, we look at the plasma free hemoglobin as well. Next, we look at the coagulation parameter because it is the extracorporeal circuit, so there is a more risk of clotting. So we heparinize the patient well, and we target an ACT in the beginning at the initiation of ECMO around 300, and during the ECMO run it is usually kept between 160 to 180, and we keep checking the activated clotting time every 6 to 8 hours, and PTTK should be maintained between 60 to 70 seconds, which at least once in a day should be monitored. Next, then we look at the ECMO system itself for its accuracy, efficacy, and safety. So next, so for accuracy, we look at the blood flow rate, gas flow rate, revolution per minute, and the membrane function. So we keep assessing these at a regular interval. Next, so for looking efficacy in the VA ECMO, we look at the mean arterial pressure of the patient and look at the pulse pressure. For efficacy of VV ECMO, we look at the gas exchange levels, and we monitor the lactate and mixed venous saturation to assess the tissue perfusion. Next, for the safety, we always look for clots, we look at the different oxygenator pressure, we look at the coagulation status, we keep monitoring with the echocardiography, we look at the hematological biochemical parameters so that there is no safety issue. Because what is important here, we have to integrate the machine and man, because the patient is integrated with the machine, and it is said that it is not the machine which is important, the person behind the machine who is operating this machine is most important. So integration, one must understand the integration of these two systems, then only a successful ECMO run can be achieved. Next, ECMO is associated with a significant number of complications. We should always kept in mind the incidence of acute kidney injury is as high as 55%. Besides this, almost half of these patients require a renal replacement therapy. In the VECMO, there can be lower limb ischemia. There is a risk of neurological complications from minor to major, including the intracerebral bleed, and those patients can have an infection. There can be hemolysis. There can be these patients who are having ischemia, limb ischemia, they may require amputation. Always bleeding from surgical side, vascular access injury, or failure, pump failure. So many complications are. So one should be very, very careful. It is not important to just put these patients on ECMO, but what is most important, once we have put these patients on ECMO, we keep monitoring regularly, assessing these patients so that the chances of complication can be minimized. So ECMO is not a simple one person's task, it is a teamwork, and a team should consist of an ECMO specialist, an anesthesiologist, critical care specialist, a cardiovascular surgeon who provides the access, especially in the case of VECMO, or in cases of disaster, if there is a vascular injury, he is there to repair. Besides this, other specialties are equally important, like involvement of nephrologist, cardiologist, chest physician, hematologist, and the general surgical, because in any time patient may require any surgery associated or unassociated with the ECMO. Besides this, the team includes a perfusionist who actually runs the prime and runs the machine, a critical care nurse who is trained in the perfusion, respiratory therapist, physiotherapist, nutritionist, psychologist, and a medical social workers, including a support from the hospital administration. And the most important thing, whole team should work as a multidisciplinary team and should keep counseling the patient relative, because until you communicate well, these patients are critically ill and they have the very dynamic course in the ECMO room or in ICU. So a proper communication from the team or team members is very important and very crucial in these ECMO patients. So to conclude, ECMO is an advanced form of cardiorespiratory support. When we are doing a VVECMO, it's a respiratory support. When we are doing a VECMO, it is the cardiorespiratory support. ECMO should be reserved for those patients who have the reversible pathology or those who are having a potential candidate for transplant. With expanding potential indications and improving outcome, there is a significant interest in the early applications of ECMO gradually, and patients supported with ECMO should be managed by experienced multidisciplinary team. Then only we can expect a good outcome. Acute kidney injury is quite common in these, especially in the VECMO patient, and one must be aware with the challenges while we are handling these, integrating these machine with the patient, because there is a lot of risk and complication associated with this. But with the team approach and a comprehensive monitoring and vigilant approach, we can minimize the risk of complications and problems in these patients. Thank you very much. Next slide, if you have any question.